Welcome to tonight's talk, organised by the Governors of University Hospitals of Derby and Burton. My name's Val Haylett. I'm one of the Governors for Derby City. I'm also chair of the Members Engagement Group, which is why I'm standing here tonight. Hope you enjoyed the pre-meet and the information tables. It's always interesting to hear about different departments within the Trust. Housekeeping first, in the event of a fire alarm sounding, the doors are at the side and the back of the room, just so you can escape easily. We are recording the talk tonight. In a few weeks' time, it will be on the UHDB website on a governor's page. If you wanted to search for it, we'll also have it on YouTube because it's good to share with friends, family and other colleagues. So to commence this evening, we're going to have a short talk by Jill Matthews, who's our Chief Officer for Derby and Burton Charities, about the charity across the Trust. So, Jill.
Thanks, Val.
Right.
Thanks, Val. Hello, everyone. I'm Jill. I head up Derby and Burton Hospitals charity. I just want to spend a couple of minutes telling you a bit about what the charity does across UHDB before you get into the main topic of today. So, Derby and Burton Hospitals charity has existed in one guise or another since the early 80s, has been a charity in its current form since the early 90s and is going from strength to strength. We have three main purposes. We are here for our patients. So we do lots of things to support patients. The first, which I think most people recognise hospital charities do, we buy big bits of kit that the NHS can't afford. So we've recently bought some kit to help deliver chemotherapy, to improve outcomes for women with ovarian cancer. We are looking at how we improve outcomes for all patients with cancer at the moment and looking at how we might provide more scanning equipment into the hospital. We also provide a lot of the things that make a difference to patients' experience. So hopefully as you've travelled the hospital, you've seen art, or heard music, or seen some of the great installations that we've got in the gardens. That's all provided by the charity. And we work really closely with our colleagues in the Trust to try and make the clinical areas welcoming, comforting, and a nice place to be treated, rather than always being country cream, it's called, the colour we paint the walls. So we work really hard to try and make that a better experience for patients. We also do a lot for our staff. So we firmly believe the better trained and supported our staff in the hospital are, the better they will do for our patients. So we run a lot of wellbeing support for our staff, including a programme we call Made in the NHS, which is things like art classes, drawing classes, a choir, to help staff with their well-being and to unwind after busy and difficult days. We also fund a lot of training for our staff at all levels, from PhDs through to British Sign Language training for our reception staff, because we believe we want to equip our staff with the skills they want, as well as the skills they need to do their job. And the third and really important thing we fund across the charity is academic research. So we fund a lot of activities that look at how healthcare will be better tomorrow than it is today, because whilst the first two activities are all about our patients here and now, we all know that there'll be patients tomorrow, and the NHS is always about innovation. So we fund a lot of things that look at how we can innovate in the NHS. So that's just a little whistle-stop tour about what we do. We raise money through a variety of means. Our staff fundraise for us. Many of our patients and their families say thank you by raising money for us. And then we have a range of corporate and business sponsors who raise money for us too. And we are immensely grateful for everybody who raises money for us. And I'm really pleased to say, and I'm hoping that's not my phone. Right. I'm really pleased to say that last year, thanks to all our wonderful fundraisers and supporters, we brought in £4 million And out of that, we've already spent £3.8 million on good things for UHDB. And I'm hoping this year we'll be able to do even more, raise more money and do more good things for our patients and staff here at UHDB. So that's all I'm going to say. Thank you for listening, and I hope you enjoy the rest of the talk. If you see me disappearing, one of the great jobs I get is Marks and Spencer's donate flowers to us every week, and I've got a car full that I'm going to deliver to our ED staff shortly. So if I'm not here for the whole thing, it's just because I don't want the flowers to wilt. Thank you.
Thank you, Jill. It's always interesting to hear where the money's going as well and what good work you do. It's brilliant. So now I'd like to introduce Heather Spooner and Donna Tyler from our therapy team at Florence Nightingale Community Hospital, otherwise known as Finch. And I'll leave you to it. Thank you. Thank you very much.
So I'm Heather Spooner. I'm an occupational therapist who's specialised in fatigue management and work with the Derby CFS ME service, although we were about to change our name to ME CFS service.
And I am Donna Tyler, team lead and physiotherapist by background for the ME CFS service. I'm going to hand over to Heather to do the first part of the talk, and then I'm going to come in and talk about the actual service. Thank you.
So you may or may not be aware that someone living with ME/CFS or myalgic encephalitis stroke chronic fatigue syndrome may really struggle to be here tonight, to sit in this room for an hour, concentrating, having spent energy getting ready, travelling to and from, speaking with people, particularly people they don't know, without a huge significant cost. And that cost might land tomorrow or Friday or even Saturday up to 72 hours later through what is known as post-exertional malaise. So if you're here, very welcome to you. And welcome to those of you online who may have chosen to participate online rather than expend that energy. So what's in a name? Historically, this condition has been through several name changes and it remains ill-defined. In the UK, it was known as myalgic encephalomyelitis, listed in the editorial of The Lancet in 1956 when describing an outbreak at the Royal Free Hospital. But in the US, after an outbreak in 1984, the name and the condition got redefined as chronic fatigue syndrome. And gradually, health professionals began to use CFS stroke ME because chronic fatigue syndrome stroke myalgic encephalomyelitis is quite a mouthful to say. More recently, in 2021, the National Institute for the Health and Care Excellence, or NICE as we call it, published updated guidelines about the condition, which changed the name again. It just switched them round. So now the condition is normally known as ME/CFS. However, possibly due to name changes, a lack of research, a lack of clear definition, many people not only experience the symptoms of the condition, but also a lack of belief from those around them, from health professionals, sadly, but sometimes also often from themselves. The question, am I really ill? So what is it? It's a complex, multi-system, chronic medical condition that has considerable personal, social, and economic consequences. It has significant impact on a person's quality of life, including their physical functional capacity and their psychological, emotional and social well-being. It has degrees of severity, so it ranges from a mild form of the condition, where someone is independent in self-care, is normally able to still engage in some form of activity, maybe work, study, social and leisure, right through to very severe, where somebody is mostly bedbound, is fully dependent on others for all their self-care. And that is a very debilitating form of the condition. 1 in 4 people diagnosed with ME/CFS will have a severe or very severe form of the condition. In 2020, globally, we saw a novel virus that we now know as COVID-19. Around 1 in 10 people who caught COVID went on to develop what we know as long COVID. Around 70% of those people with long COVID had a condition that is very, very similar to ME/CFS. And many of those people, 5 years down the line, are now being diagnosed with ME/CFS. So those numbers are growing. ME/CFS is a clinically defined syndrome, so there's no specific test that confirms diagnosis. Diagnosis is usually made by the GP and is done matching against a characteristic pattern of symptoms, which involves persistent fatigue, which impacts both physical and cognitive function and is worsened by activity. Also, post-exertional malaise, often delayed up to 72 hours, which is disproportionate to the activity and has a prolonged recovery. And unrefreshing sleep or sleep disturbances, or both, maybe too much sleep or too little sleep, but it's not restoring and it's not restful or refreshing. And there can be a range of other possible symptoms, such as headaches, muscular pain, autonomic features such as dizziness, poor temperature control. Many other conditions, for example, fibromyalgia, depression, myasthenia gravis, inflammatory conditions, also have persistent fatigue as a significant symptom. So part of making the diagnosis for ME/CFS is to exclude other conditions, other possible causes for the fatigue. That means investigations should consist of other tests. And that can take time, sometimes years. It might involve a raft of blood tests or scans. It can be quite scary if you're being sent for things like scans to rule out brain tumours or scans to rule out MS. That can be quite scary and a bit of a roller coaster where you gear yourself up, is this what I've got? Only to find that those tests come back normal and it isn't what you've got. So there's a sense of relief. I don't have this nasty thing that I might have, but what do I have? It's important, though, because the ME/CFS has no cure, and we don't want to direct people to self-management if there's something more treatable amiss. Generally, though, examinations are normal, blood tests come back normal, investigations detect no abnormalities. And if they do, then it might mean having further investigations to understand those abnormalities and whether they are a cause of the fatigue. In 2021, NICE published the report, the updated guidance, and said that the incidence of ME/CFS is around 250,000. Last year, Sams and Pontin, who are authors of the Decode ME study, said that ME/CFS had a lifetime prevalence of around 390,000. So we're not talking small numbers of people. I suspect long COVID is increasing these figures. As with many autoimmune conditions, it affects more females than males. And it can affect people of all ages. So children can have ME/CFS, just like they can have long COVID. But peak onset is in adolescence and midlife, 30 to 50. New onset in older people is really quite rare. And so often older people with persistent fatigue will need many more tests to exclude what may be other possible causes. These peak ages may be significant because these ages of adolescence and midlife correspond with quite large and significant hormonal changes and life stresses, and we know that these can play a part. We still don't understand the underlying pathology and the mechanisms driving ME/CFS. possibly due to a traditional lack of large-scale research, particularly into the biomedical causes. Some people feel ME/CFS is a number of discrete, different conditions that currently we just don't have the tools to distinguish. The research isn't clear yet. There's still a lack of global consensus around definition for the condition, which makes the research and diagnosis difficult. And it also compounds the medical challenges faced by people with ME and further hinders access to support. However, there is now robust scientific evidence involving a variety of advanced biomedical testing procedures that demonstrates the presence of fundamental biological abnormalities in people with ME/CFS. These abnormalities are related to defective cellular energy production and the dysfunction of immune, hormonal, and neurological systems. I've put the reference up there. We can take you back to that at the end if you wish to have a further look at that. Because we don't understand what causes ME/CFS, diagnosis is by exclusion. It's challenging and its treatment is self-management strategies only. There's no known cure, there's no medication, and the prognosis is unpredictable. Some people will see improvement with the self-management strategies. Others are unable to put the strategies into practice, and some will struggle to improve. However, in the interests of hope, I want to tell you that I personally have seen, and in our service we have seen, and in the wider community, we have seen people improve. Some to the point where they can return to a quality of life that they are satisfied with, regaining employment and roles that they wanted to. However, this doesn't happen for everyone, and I can't make any promises, but many people do see improvement with the self-management strategies. In 2022, the All-Party Parliamentary Group published their report, Rethinking ME. Please see their website. It's a way of raising your voice, and there's lots of information there. The APPG is a cross-party group of MPs and peers with a common interest in ME/CFS, which seeks to improve the health, social care, education and employment opportunities for people with ME and encourage biomedical research into the cause and treatment of ME. Its report states that people with ME require targeted service provision, including health and social care, and that research shows that when lost taxes, welfare benefits and health and social care costs are considered, the total cost to the UK economy for ME/CFS in 2014 to 15 was at least £3.3 billion. Provision has a long way to go before it's adequate. For instance, the Nottingham services are not funded to see people who are severely affected. Leicestershire currently has no dedicated service at all. And here in Derby, we're seeing referrals for people living in those areas coming to us. The report made several recommendations around 5 themes, and I've put the themes up there. I do have information about them, but tonight is probably not the time to go into that, so please see the website or talk to me after if you wish to know. So there's greater spending on biomedical research, an encouragement or a recommendation that all health professionals follow the NICE guidelines in 2021, that children and young people are seen by paediatricians, which they are here in Derby, that the welfare benefits system takes into account someone's capacity to engage with the process of application, and that insurance companies don't push people into prescribed forms of treatment which may not be tailored to them and may be harmful to them. And that the COVID-19 and the ME community work together because there's such an overlap between the two conditions. The British Association of Clinicians in ME/CFS, or BACME as we call it for short, is a multidisciplinary national organisation for the UK, which provides information, resources, education and networking opportunities to UK professionals to deliver high quality care to people living with ME/CFS. In 2021, based on the current research, it published An Introduction to the Theory of Regulation, which helps to explain some of the array of symptoms that we see within this condition. It discusses where the systems responsible for homeostasis can become dysregulated. So homeostasis can be defined as the body maintaining balance to provide ideal internal conditions to support long-term health and survival. So if I'm sat down and I go to stand up, then my blood pressure has to change in order to accommodate gravity and make sure that my brain continues to receive the oxygen it needs and I don't faint. That's an example of homeostasis. When we move more quickly, our breathing rate and our heart rate changes, it normally rises, in order to accommodate the extra fuel that our muscles need. This is homeostasis. The main systems that the research suggests become dysregulated are the HPA axis, which is part of the neuroendocrine system, the autonomic and immune systems, mitochondrial function, and metabolic disruption. And I'm just going to walk you through a little bit about those systems. The HPA axis is a feedback loop between the hypothalamus, the pituitary gland, and the adrenal glands, and it's responsible for regulating metabolic, cardiovascular, immune, reproductive, and central nervous systems. Dysregulation of it can lead to symptoms of insomnia, difficulty waking, feeling cold all the time, reduced appetite, nausea, weight changes, low mood, fatigue. The autonomic nervous system involves the sympathetic, parasympathetic, and enteric systems. It's a fast-acting system responsible for blood pressure, circulation, heart rate, breathing rate, body temperature, sweating, digestion, including saliva and digestive enzyme production, gut motility, metabolism, including regulation of blood sugar, the balance of water and electrolytes, amongst other things. Symptoms of dysregulation of the autonomic nervous system may include orthostatic intolerance, postural hypertension, muscle pain, fatigue, headaches, palpitations, altered breathing patterns, hypersensitivities, gastrointestinal symptoms, temperature dysregulation, anxiety, cognitive disruption, hypersomnia, nighttime arousal. We often see an imbalance with the sympathetic nervous system being in dominance. So this is more sensitive and reactive to triggers, and the body can become stuck in a high sympathetic arousal state. The sympathetic system we know colloquially, I'm not getting my words out, sorry. It's often referred to as the fight or flight system. And the HPA are systems primarily involved when we feel anxious and stressed. Chronic stress can lead to higher cortisol exposure and greater sensitivity of the HPA. It can also lead to adrenal gland sensitivity and then enhanced sympathetic drive. And so you can see that this can become a vicious circle. The immune system plays a part in healing, growth, cancer prevention, reproduction, as well as what we know it for, protecting us from threats of bacteria and viruses. Symptoms of dysregulation may include malaise, which I believe feels like flu, tender glands, sore throat, pain, headaches, cognitive fatigue, new sensitivities to foods and medications. Mitochondria are found in almost every cell of our body and are constantly adapting and communicating with other structures to produce appropriate amounts of ATP, or adenosine triphosphate, which is the energy currency of our cells. Many factors can disrupt the function of mitochondria, including infections, aging, lack of physical activity, oxidative stress. Metabolic processes are involved in the conversion of fuel into energy. So that's what happens when we eat, making building blocks such as proteins, fats, carbohydrates, and the elimination of waste. Symptoms of disruption or dysregulation may include exercise intolerance, post-exertional malaise, muscle pain, medication sensitivities. So you can see these systems are both complex and they're widespread. They affect many parts of how our bodies function. They also interact with each other and impact on each other. It's also thought that there may be changes over time. So someone newly diagnosed with ME/CFS will have differences in their medical tests, potential. They will have differences compared to someone who may have had it for much longer. In some people, there may be pre-existing vulnerabilities to ME/CFS, such as possibly genetic factors. We know that the condition can run in families, but doesn't always. So a bit like the inflammatory conditions. Also, developmental changes occurring during childhood. So many patients were highly active before becoming unwell, often describing an inability to rest or relax prior to the illness. Some people really enjoy being very active, and I often feel that people have been running at 120% before the onset of this condition. But that may indicate a pre-existing highly responsive sympathetic nervous system, that alert mode, that switched on mode, and poor responses in the parasympathetic nervous system, so the rest mode. We call these predisposing factors. They're looking at the question, why me? Some conditions, including hypermobility and autism, may also constitute an underlying vulnerability due to their associations with autonomic system dysfunction. Dysregulation of homeostasis can be triggered, or may be triggered, by a virus or another stressor, and we call these precipitating factors. Why now? In some cases, there's a clear trigger for onset of symptoms. So, for instance, a viral infection. Many people who have glandular fever may go on to develop ME/CFS. We know that COVID-19 might be a trigger, Lyme's disease. There are several different viral infections that can potentially lead on to ME/CFS. Or it may be a major emotional event, such as a bereavement or a series of bereavements. But for others, it feels more like the condition gradually comes on over many years until someone notices that they're not able to do the things they used to be able to do. Treatment is aimed at allowing the body to regain regulation by optimizing health and gaining understanding of what are the specific perpetuating factors for this person. So what are their triggers for their dysregulation? What are their barriers to re-regulation? And which strategies are going to help them to rebalance the sympathetic and parasympathetic systems? I'm now going to hand over to my colleague Donna, who's going to talk to you about what we do as a service here in Derby.
Thank you, Heather. So the Derby ME/CFS service is based at Florence Nightingale Community Hospital, which is on London Road in Derby. The initial assessment is preferred to be in person. However, follow-up sessions can be virtual to avoid the energy demands that is required from travelling to and from the hospital. So we are a multidisciplinary team, which means we are made up of occupational therapists, physiotherapists, cognitive behavioural therapists, and we also have access to rehabilitation consultants that do offer us clinics as well. Referrals are only accepted from GPs and consultants for people who meet the diagnostic criteria for ME/CFS based upon NICE guidelines. It should include a referral letter, history of fatigue and any comorbidities, along with up-to-date blood tests and investigations to be completed to exclude other possible causes. And we do ask referrals to go via our electronic referral system. The service has traditionally taken out of area patients, like Heather said. Unfortunately, some services aren't commissioned to take severe. We are looking at that at the moment as a service. Unfortunately, we are unable to accept people who have fatigue as a symptom of another condition, as the service is only funded for a diagnosis of ME/CFS. So moving on. So ME/CFS diagnosis. So all the symptoms should be present for at least 3 months and cannot be explained by another condition. So the first symptom we look for is debilitating fatigue that is worsened by activity. Post-exertional malaise after activity, and this is not usually present in other conditions that cause fatigue. It can last for hours, days and weeks, and it's not proportionate to the triggering event. Unrefreshing sleep or disturbance in sleep, and cognitive difficulties, sometimes described as brain fog. So this can include difficulties concentrating, short-term memory, word finding difficulties. It can be difficult to follow a conversation, and you can be slow to initiate the speech to begin with. So medical assessment and management. So the referrals are triaged to either a medical initial assessment and management, and these tend to go to a medic based on the lack of diagnosis, comorbidities, or like Heather mentioned earlier, when there is an older age of onset, sort of routinely over 70, as this is more unusual with ME/CFS. Or they can come straight to a therapist for their initial assessment. So the medical input may include symptom management, looking at pain or mood, referral on for further investigations, for example, obstructive sleep apnea. It can be advised back to the GP, or provision of medical reports, a diagnosis of ME/CFS, and referral to a specialist therapy team. So moving on, so the treatment format. Most initial assessments we ask to be in person because we feel that's nice to actually meet the therapist and for us to meet the patient. However, then following on from that, we do offer telemedicine, which is on Attend Anywhere, or the telephone as well. Telephone can be quite difficult on energy demands. So this is kind of if somebody isn't able to access telemedicine or come in face-to-face. The typical appointment can last up to an hour and a half for the initial assessment, but we are aware again, because of the condition and energy demands, that we can spread this over more than one appointment. Home visits are generally limited to the local area and are for very severe or very severely affected only. And we obviously try and adhere to patient choice as much as possible. So a bit more about ME/CFS therapy. So we follow NICE guidelines. We carry out a holistic assessment that's tailored to the patient, looking at the physical and functional capacity, psychological and social impact of the symptoms. So that could be like changes in roles and responsibilities, changes to work, changes to study. Therapy is about helping people to understand and implement into daily life the self-management strategies to manage their condition. It aims to reduce the severity of the symptoms, improve symptom management, and improve the quality of life, including support with engagement in social and leisure activities, education, and employment. Sessions are reviewed just to check that we are on track with goals, and at the end of the sessions, we offer a patient-initiated follow-up appointment, which is where then the ownership is on the patient to contact the service should they need a review in the future. And this tends to be for 1 or 2 further appointments just to see how they're managing with their strategies. As Heather said, there's currently no cure, therefore it's important to have realistic expectations. Therapy may explore what does recovery look like, might not be in the same place as prior to onset. It will look at the person's values and their goals, and the direct application of the strategies to be meaningful and satisfying. And we look at nourishing activities as well. Thank you. I'm going to hand back to Heather.
So I just wanted to walk you through what some of these self-management strategies look like. So we look at energy management, which looks at different forms of demand from activity. So we get physical demand from physical activities, so walking, running, swimming, just doing housework or coming to work. Cognitive demand, so completing a form, reading. Emotional demand might be an argument with somebody or it might be watching your favourite football team. Sensory demand, so changes in noise, temperature, smell, light, touch. It takes a lot more energy to wear a new pair of shoes than it does an old comfortable pair of slippers. And social demand. We all know people who are less demanding on us or more demanding on us. It's important for each person to understand how these different forms of activity demand impact them specifically, and which ones are more triggering for their fatigue than others. Treatment aims to help each person avoid overexertion and the consequent post-exertional malaise by recognising the early warning signs to rest, spreading out activity demand, and rotating different types of demands. Sometimes a change is as good as a rest. This often involves planning and prioritising skills and learning to say no. No to myself and no to others. Some people have found the Visible app as a useful tool to offer in-the-moment feedback on how activities are impacting them. It can look at your heart rate, I believe your breathing rate, and just give you an idea. Is it getting dressed in the morning that is making me feel fatigued, or is it walking the dog? Or is it that phone call because mum's rung that day and told me she's poorly? Acceptance is of a lower... Sorry, I'll just scroll down. Don't want to miss anything out. Acceptance of a lower demand threshold is vital in moving away from a boom and bust activity pattern. So we often see people coming to us for very reasonable reasons in a boom and bust pattern where they are doing too much activity, followed by the resultant post-exertional malaise, and enforced rest, and then that repeats. That pattern is really quite destructive. And so part of energy management is to help people move to a more paced management of energy demand. Rest needs to be effective. Many people in the Western world don't seem to know how to rest well. It's not something we're taught at school. They may equate rest with sitting browsing on their phone or watching the TV. Effective rest promotes parasympathetic function and is matched to the type of activity demand which is causing the signs of fatigue. For example, cognitive activity, if you've just spent an hour completing a form, then you may need a cognitive rest. Sensory demand needs a sensory rest. Initially, some people need to take a total rest. So that might look like lying down in a room with low sensory demand, alone, whilst people learn the nuances of the different sorts of rest and how to rest on the go. It's important to rest before you really need to. And it's important to learn how much rest you particularly need, because too much rest can be just as detrimental as too little rest. Many people with ME/CFS have sleep dysfunction. They may be getting too little sleep or too much. It may be broken or at the wrong times, all of which can be harmful and dysregulatory. There's more and more research affirming the old saying that certainly I grew up with: we are what we eat. Seeing food as medicine that can fuel and feed our bodies well if it's nutritious and in the right quantities can help to eliminate some unhealthy habits that we've picked up. So part of treatment is optimising sleep and diet, because these are important foundations for health regulation. Helping people to manage stress well aims to rebalance the sympathetic and parasympathetic systems within the autonomic nervous system. Activities that nourish us and top us up emotionally are often seen as luxuries and drop off the priority list when we start to become ill. However, this promotes a chronic state of high alert or toxic stress. Those activities that top us up are often the very ones that promote the parasympathetic nervous system and help keep us in balance. So re-establishing or learning new nourishing activities is an important part of re-regulation. Rediscovering joy can be really helpful and healthful. Understanding how our thoughts impact our emotions and our physiology can be a key part of stress management. So we have CBT therapists within the team to help people where unhelpful thinking patterns have become barriers to moving forward. They can also help where anxiety and depression have become problematic. These might be pre-existing to the onset of fatigue or as the result of the impact of living with chronic illness, decreased functional capacity and the associated loss of roles and dreams. There's often a grieving process to go through when you're diagnosed with a chronic illness because you're losing not only roles in the moment, but potentially dreams for the future. Relapse is part of recovery. People often feel that it's a bit like a game of snake and ladders. 1 minute they're moving forward, the next minute they've slid back several steps. However, the aim of treatment is to learn how to effectively manage relapses so that they become less severe, less impactful, and less frequent. But re-regulation is only part of the process. It's the first part. Once we see signs of re-regulation, then we can start to very gradually and gently rebuild towards regaining the desired roles and capacity. It's really important to only work at the pace the body is comfortable with. So sometimes old typical patterns of building fitness just don't work and can actually be harmful due to the changes in thresholds and the imbalance between the activity and the impact, and that can cause increased symptoms and relapses. People understandably can feel anxious about risking increased symptoms and relapse and can be overly cautious. Or they may just catch a glimpse of normality and risk overexertion. So finding the right pace to rebuild can be quite tricky. We all need to remember that people are learning on the job. So often these skills and things, they look easy on paper, they're quite difficult to put into practice, and they involve changing habits of a lifetime. They're learning on the job at the very time when they have less capacity, and less capacity for learning and less capacity for change. Some days they will get it right, and other days they won't. Some days they'll have capacity for it, and other days they won't. So learning to be kind and compassionate is a key part of the process. We asked people from one of the groups what they had learned about when they need to help them, what they have learned about what they need to help them sustainably manage their ME CFS well. So these are some of their answers. Walking in nature, eating the right stuff, putting myself first, learning to say no, healthy routines for sleep and rest, cuddling, joy, learning to ask for help, and being aware of when I have low energy. A wellness and recovery plan, or WRAP, as it is at the top of the slide, is a way that we use to record learning about what strategies have worked for each particular person. Regular review of that WRAP can help someone to sustain the strategies that they've implemented and that have helped them improve. And this can be included in their care plan. A blank care plan can be found on the service website and is offered to each person coming through the service. It helps someone to organise information about ME CFS in general, the person's specific symptoms, medication, treatment, and the strategies all into one place. And it can be useful to discuss with others as appropriate. So, for instance, if someone with ME CFS is going into hospital, it's completed and kept by the person with ME CFS, although therapists and health professionals can add to it during treatment as appropriate. So our service website, which can be found on the hospital, the University Hospitals of Derby and Burton Trust website. If you search for, at the minute, chronic fatigue syndrome, that will take you to our service website, and it's got access to information and links to a series of 6 short videos which look at the basics of any management and energy management and optimising sleep. There are also several audio tracks looking at different styles of relaxation techniques, and these can be a great starting place to learn to rest and relax well. We have national charities, Action for ME and the ME Association, who advocate for people living with ME CFS. And we have a representative here today from a local group, ME Positive, who are based in the East Midlands. The websites for each of these charities offer lots of helpful information and links to further resources. And in an age where there's lots of information around, some of which is reliable and some of which isn't, I would suggest that these are good places to start. To end, I just want to play you an audio recording of somebody's story who's been through our service. It's only a few minutes long. And then we'll answer some questions if there are any.
For as long as I can remember, nearly 20 years, which is almost half my life, I felt unwell and exhausted most days. I used to wonder how other people managed to adult, how they had the energy to work full time, raise children, stay on top of their homes, socialise, exercise and maintain romantic relationships. I was barely holding on to my 9 to 5. I came to the conclusion that maybe I was just lazy or dramatic or a hypochondriac. I'd often find myself slipping away just to rest and gather myself at social functions and even at work at times. I couldn't go to the gym without being bedbound for days. I started sleeping up to 14 hours a day when I could, and even then I still felt exhausted. Things like brushing my teeth or tidying up the house became massive tasks at times. It would take me a week to get through basic chores, and because I lived alone, I was able to mask just the effects it was having on my life. Couldn't focus on TV or books when things got to their worst. I'd travel for work but have to leave early to stay in a hotel overnight and then stay longer the other side to recoup for the drive back home. And then when I did get home, I'd sleep through the whole weekend just to recover so I was able to be ready for work the following Monday. Socially, I disappeared. Maybe the odd early dinner a few times a year, but that was it. I went to the GP so many times, but every blood test came back normal. I was told, just get more sleep. That was the only advice I got, but nothing was changing and everything just kept feeling harder. Eventually, I decided to go and see a private consultant who mentioned chronic fatigue. And after taking some more blood tests, which again all came back normal, he referred me to Derby Hospital to get a diagnosis. That's when everything changed. I had a couple of appointments and things started to make sense. I wasn't lazy, I wasn't going mad, I had chronic fatigue, and someone believed me. Over the next 10 months, I worked closely with an incredible nurse called Heather. She helped me completely reframe how I understood my condition and my body. She taught me how to notice the early signs of a flare-up and take them seriously. That pushing through wasn't brave, it was actually destructive, and that rest alone and sleep don't fix chronic fatigue. But balancing activities and fueling myself properly can help me stabilise it. She gave me small practical tools that made a big difference. For example, wearing sunglasses and headphones in busy places to reduce sensory overload. Using positive thinking to shift my mindset without being fake about it. And one of the most useful techniques for me was the tense and release method, physically learning how to let go of tension in my body. And then also just taking 5 minutes and learning how to refuel myself. Fast forward to now, I have a normal life, but I do live it differently. I pace myself, I listen to my body. I know I'll have periods of remission, but I never take them for granted. I remember my first period of remission, I thought I could conquer the world, and lo and behold, 3 days later, I was laying in bed again. I'm honest at work about what I need. For example, time to absorb information, flexibility when things feel heavy, and actually the straight refusal to say no, I can't travel this week, I'm not feeling well enough. And surprisingly, I'm supported. This has enabled me to enrol on a course. I've started running again, not far, but I never thought I'd be able to say that. I'm more social, I have a partner who I now live with, and I'm genuinely happier. One of the biggest shifts for me is that I have boundaries. I don't feel guilty for saying I need to pause or this will burn me out, so I'm going to step back. I say it clearly and I say it kindly, because if I don't, it's going to be me that's impacted the most. Having my diagnosis has changed my life and given me my life back after 20 years of struggling. I know there will be periods where I'll struggle again, but I also know that I can get myself back into remission and the steps I need to take myself to be at my best.
think Val's going to.
Switched it on, have I? Is that? That's good. Any questions? I will say while you're thinking, the slides will be on the talk, on the video, on the website once it comes on in the next week or two.
Thanks very much for that. I was interested in what follow-up you do. I think Donna referred to it briefly, but I didn't quite get that. So do you work in conjunction with GPs to keep an eye on people 6 months later, 12 months later, or do you simply not have and 2 years later, or do you just not have the capacity for that?
So once we've done our initial assessment, thank you, by the way, our initial assessment, obviously depending on what we find and what we discuss with the patient, each patient's needs are individually tailored. So we decide how often we see that patient and, like I say, in what means. So that might be monthly. I think we find patients can't attend more often due to the fact of, like you say, the post-exertional malaise, the cognitive load of attending appointments. But there is no set a year down the line they're going to be discharged. It is all individually tailored. So I'm sorry that's a big answer, but it does depend. But people, we have the group that they can attend as well. We do place them on an open appointment, again, which is tailored to that specific patient. So it could be for 3 months or 6 months, and then they can have that onus on them then to contact the service should they need a review. But it really is dependent on the patient. Sometimes we, towards the end, might see them every few months, sort of every 3 months, and then again at 3 months. So it really does depend how they're able to take on the self-management strategies. We've been known at times where if patients feel at that time that it's not the right time to attend the service and they need a break, we can place them on the open appointment, and again, they can kind of come back. But there is that re-referral pathway back through the GP. So at that point, that patient is discharged. If in 6 months, like you said, a year's time, 2 years' time, they need to come back, they just go via the GP and go through the re-referral process. Okay.
We've just got a couple of questions from Teams as well, if we can go there first. From Michael, how do you manage associated conditions such as POTS or MCAS? And he also says, what scales do the clinic use to measure patients? Do they use the FUNCAP scale?
So for people who don't know, POTS is POTS, or postural orthostatic tachycardia syndrome, which is has been said it's for people. It's people who don't like standing up. They feel very dizzy, sick, have temperature fluctuations, and increased heart rate. MCAS is mast cell activation syndrome, and is where the body is hypersensitive or allergic to many, many different things. These are quite common with ME. No, I'll rephrase that. I don't know that they're quite common. We do see them with people with ME/CFS. Then there's certainly known overlaps between the conditions. How we manage them, Michael? We have a basic knowledge. We don't have a specialist knowledge in these other conditions. So it is one of the things that we look for at initial assessment, and we'll refer on to, say, a cardiologist or back to the GP if we don't, as therapists, I can't refer to a cardiologist and I can't refer to an immunologist. So it may be that I have to refer back to the GP and request that those referrals are made. And we can also help people, we can direct people to resources for help with management of those sorts of conditions. And the other part of the question was how we measure it.
Yeah, Michael's put several questions on. I don't know if you want the next one as well. Many with ME don't recognise fatigue as a symptom. What is the clinic's understanding of post-exertional malaise, and how can you screen for it?
So our understanding of post-exertional malaise is that it is a key symptom for this condition, that it is feeling very, very unwell and very low in energy. Some people describe it as like having flu. That is often after an activity, but it may be delayed by up to 72 hours. So that can make it really quite tricky to understand what has caused it. It can take a long time to recover from, and it's disproportionate to the activity. So to give you an example, if somebody's comfortable capacity for gardening is 30 minutes, but they do 45 or 50 or an hour and a half for all sorts of reasons, then they may experience post-exertional malaise, which may hit that day, or it may hit the following day, or it may hit 2 or 3 days afterwards. But it might take them a week to recover from that. But tracking it back, so I have a lady I'm working with at the minute whose post-exertional malaise hits approximately 3 days after the activity. And so tracking back what it was that caused the post-exertional malaise is quite tricky. And we have to do quite a lot of detailed digging around for that. How we measure it. There are scales that can assess for post-exertional malaise. We don't routinely use those at the minute. We are looking at changing our assessment clinical questionnaires at the minute. There's some new ones coming out that we're in the process of looking at, exploring, seeing whether we feel that they're suitable. So, yeah, it's in a state of flux at the minute.
There's a question from Simon. I found the talk very informative. As a sufferer, I understand much of this because I'm living it. How do we get the knowledge to GPs and the wider HCPs? I can't be the only sufferer who hasn't been believed by their GP.
We're with you on this one. We get some referrals from GPs who obviously don't understand the condition as well. We have tried and tried to be invited in to speak with GPs and to educate GPs about this condition. They are very, very busy people, and there are not enough GPs to go around. The APPG, the government party, did try, it's part of their recommendations for the Royal Medical Colleges to bring forward training and include training to GPs and health professionals. And I believe that there is work underfoot for a recognised national training programme for health professionals. So hopefully things will begin to change, but it's a very slow progress, and I'm very sorry, Michael, I agree with you. Simon, sorry.
I'll do one more from here and then we'll go back into the room. This one's anonymous. Are you able to prescribe off-label medications such as low-dose naltrexone, LDN, which has been shown to help some people with ME?
No, unfortunately not. We follow NICE guidelines, and at the moment, within NICE guidelines 2021, there isn't any kind of prescriptive medication to take. We just follow their guidance in the self-management strategies.
Low-dose naltrexone is something that is widely talked about on the internet at the minute amongst communities of people, particularly long COVID and ME CFS. I believe there is a doctor up in Glasgow who is prescribing it privately. My experience of people who I've known who've taken it is some people find it does nothing. Other people have said it has shown some improvement. I think it's one of those things that we just don't know enough about at this point in time. It doesn't have robust evidence. It has a little bit of evidence that seems to suggest for some people it might be helpful, but not for everyone. And it's not an easy medication. It has some quite nasty side effects. So I would recommend, if you're considering it, please talk it through in depth with your GP before going ahead trying to find it.
Hi. First, I'd like to thank you both for your time giving us the talk. You said you're at the Florence Nightingale Community. Whereabouts are you? Is it signposted to tell us? And is there information there for people with ME so they can pick up or take away or anything like that as well?
So we are based at the Florence Nightingale Community Hospital. We're based in the Specialist Rehabilitation Centre, which is, if you stand looking at the main entrance, it's just to the left.
Is there a sign saying that ME?
No, it's signposted Specialist Rehabilitation.
Is there any chance that can be changed so people are aware that it's there, or is it not possible for people to, people who are not aware that you're there? Is it possible for the sign to be changed, requested at all?
I don't know. We can explore that.
Yeah. And is there leaflets there to, with some information about ME for people to pick up?
We have some paper leaflets, but most of our information is online now, primarily because, to be honest, most of the people attending our clinics are online now. I would say 60 to 70% of my caseload is virtual. It's through a computer. So paper handouts are not helpful in that situation. So most of it is online on our website. But we do have some paper versions around.
I've just got one more question. With new doctors and GPs that are coming through, as you said, that there's more knowledge possibly going through. So with the new doctors and GPs coming through, are they getting, is there a possibility that funding allows them to have a basic knowledge about ME, so where when people come in, especially with a long COVID, is that funding possibly going to, that possible funding going towards them? So when they come up, they know a little bit about ME and what the repercussions of it is, and they can see from a person maybe.
From the funding perspective, I'm afraid I can't answer that question. I don't know.
Thank you for your time.
I know the Integrated Care Board, the ICB, are looking at the long COVID service, and I don't know. We're not party to those discussions at this point in time, so I'm sorry, I don't have any better answers. Thank you.
Yeah, thank you very much for those talks. I've got a couple of questions. One is sort of about numbers. I wondered how many people you've actually got on board with ME here in Derby or the Derby area, and also how many people you actually see at home. You said you're also looking after the severe patients, just to get a rough idea of numbers to start with.
I suppose a quarter of our caseload is severe to very severe. It's that 25%. So initially we try and offer that home appointment, but with us being based in Derby, obviously that limits us to the Leicester area. We can't do home visits in Leicester or kind of to North Nottinghamshire. So we try and do that initial assessment. We go out to do a home visit, and then thereafter we tend to do telemedicine. It might be that we liaise with the carers or the family members as well.
Numbers. How many people have you got on your service?
So referral numbers, we get in monthly about 50 and 60 referrals a month. It's not to say that we accept all of those, because again, we do have to liaise with GPs. We are in the process of looking at our referral form to make it hopefully a bit more straightforward to refer to us with GPs, so that bits aren't missing. Obviously, because it is a condition of elimination, if parts are missing off the form, we end up sending it back. But we generally get about 50 or 60 a month.
Okay, I just wondered if we could get a bit of an idea, actually, how many people in Derby are affected by ME. Have you got any sense of,
I don't have it to hand, sorry.
No, okay. And the other question is about ME triggered by long COVID. Have you seen any cases come through to your service? Because like you said, obviously there's the long COVID service, which is completely separate. But have you seen any people with ME triggered specifically by long COVID?
Yeah.
So initially, we saw quite a lot of people. Most people, there was just the long COVID assessment unit, and they were referring direct into ourselves, as well as another department within the hospital. And numbers went through the roof. Then the treatment part of the long COVID service came on board, and our numbers dropped. We weren't seeing anybody triggered with long COVID. That is changing, and we're keeping an eye on how it's changing. As I said, the ICB are looking at the long COVID service. I know that funding for the treatment side has been on a yearly basis rather than an ongoing basis. And so we're not really sure what's going to happen, whether, but we are seeing, I would say, a small but steadily increasing amount of referrals from GPs saying this person has ME/CFS, and when they sit in front of us and we assess, it's been triggered by COVID.
And do you see any difference between those people and your other ME patients at all?
Sometimes. And that's quite difficult to quantify. I would say that sometimes people who have been triggered by long COVID have some perhaps more symptoms that wouldn't be typical for ME/CFS.
What do you mean by that?
Oh, all sorts of different things. So one of the symptoms that I've seen with somebody with that was triggered by long COVID is where their gut feels like it's in a washing machine, or that's how they describe it to me. And that's something that I hadn't come across before particularly. I mean, people with ME/CFS often get gastrointestinal symptoms, but not described like that. It would come on very suddenly. Oh, you've got me on the top of my head,
don't worry.
sorry.
Thank you very much. Thank you.
Caroline from ME Positive again. You said 56 to 60 referrals. Are you a full-time clinic? It sounds quite a high caseload, and what kind of waiting list does that result in?
So at the moment, the waiting list is around 8 to 9 months to see a therapist. We sound a lot. We've got at the moment 6 therapists, including myself, who is obviously team lead as well. And we have a cognitive behavioural therapist. We have just recruited to a second cognitive behavioural therapist from somebody that had left the service a year ago. But we are all very part-time. It sounds a large number. It probably makes up 4 whole-time equivalents, 3.5. So we are spread over part-time hours. But because of the flexibility, we see initial contacts, new patients every month, but they slot into the patients that we already have seen, if that makes sense. So we could be seeing somebody towards the end of their treatment, maybe every few months, and then we can slot our new assessments in where possible. Is that okay? Thanks, Caroline.
Yeah. We have got another couple or so on Teams. If I could just, there's one from Sarah. I'm curious about the comment Heather made about post-exertional malaise leading up to 72 hours. My experience has been that the PEM has lasted far more than this, but could it be an accumulative effect?
So what I meant, and I'm sorry if I wasn't clear, is the onset of the malaise can start up to 72 hours later. It definitely, as your experience is, it can last for far longer than 72 hours to recover from it. So my apologies for being unclear about that.
We've got quite a few on here, so I will just pick and choose a few. There's an anonymous one. I was diagnosed with ME in 1997 and have fibromyalgia and now long COVID. Can my GP refer me into this service? I had, what does he say? I had for over half my life, so 28 years, and it's very debilitating and makes me depressed.
Yes, 28 years is a very long time to be living with those conditions. Yes, I would imagine, without knowing more, that you should be able to be referred into the service via your GP. You will need to have a raft of blood tests to make sure that there are no other contributing conditions, although obviously fibromyalgia and long COVID both have fatigue as a significant symptom, but people can have more than one condition. So yes, talk to your GP.
One more from another anonymous caller. Would the clinic be able to provide evidential support to patients who maybe need to apply for adult social services or some form of benefit support?
So we do sometimes provide evidence for people who are currently attending the service. Unfortunately, we don't have the capacity to offer that for people who are not under the service currently.
But there is online, so the resources that we put online often have supporting evidence and advice for people that need to apply for benefits. So the slide that we had with a lot of the links on, the ME Association will have quite a bit on there about supporting, and possibly the social services website for the county council that you're under.
Okay. I've got one more there from Natalie. I have POTS. Could I not also have chronic fatigue? I can definitely meet the criteria. Does this mean I wouldn't be able to get a referral from my GP?
I'd probably say refer then.
That's a tricky one because POTS and ME/CFS can overlap. I guess what we would need to do is assess you and look at what came first, your timeline of symptoms, and try and establish whether the fatigue is due to the POTS or whether it's different and separate to the POTS. So I would speak to your GP. We do often get GPs referring in asking for a specialist opinion.
Have we got any more questions in the room at all? Just conscious of the time, but I think we've reached the end of the questions, have we? Lay down. So I'd like to thank everyone for coming this evening. As I say, the talk will be on the UHDB website in the next couple of weeks. It will have the slides on as well, so you will be able to look the references up if you require them. And as Donna and Heather said, we have got a lot of information on the UHDB website if you search on there. So I'd like to thank them both for a really interesting session and a good Q&A session as well. Thank you very much. I'd like to thank all the staff as well who's helped to support the event, Ross and the AV team, Victoria and Fraser, our BSL interpreters have done a fantastic job again, Alex in IT and Pip, our wonderful secretary who's organised us so well. She does a sterling job for us. If you've got a feedback form, we're really grateful for it. If you haven't got one, there are plenty at the front where everybody left empty seats for some reason, but there are plenty of forms around. It's appreciated if you could do that. So thank you all for attending. Have a safe journey back and hope you can exit the car park. The barrier should just lift if you're in the university car park. You shouldn't need to press any buzzer. You can just escape. So thank you all very much for coming. Thank you.